Now let's begin with the second topic of our today's lecture, which is the renal cell carcinoma. In this section, we will talk about the epidemiology of the renal cell carcinoma, pathology of the renal cell carcinoma, and how this renal cell carcinoma present and the signs and symptoms associated with renal cell carcinoma. So carcinoma of the renal pelvis and ureter. Ureters are the tubes that carry the urine from the kidneys to the bladder. So, and the renal pelvis is the inside of the kidney. So that carcinoma of the pelvis and the ureter. Here, it is associated with the chronic phenacetin abuse. So the drug phenacetin that is now restricted by the FDA, which is the Food and Drug Administration agencies, because of its bad effects and because of its causing the renal carcinoma, and also it plays a role in the development of the bladder carcinoma. So this is the kidneys. We have the chronic phenacetin abuse leading to the renal cell carcinoma. Then we have aristolochic acid consumption, which is also known as Balkan nephropathy. Upper tract urothelial carcinoma linked to hereditary non-polyposis colorectal cancer. So it is also associated with non-polyposis colorectal cancer, upper tract urothelial carcinoma. So it is associated with the renal cell, pelvis and ureter carcinoma is associated with phenacetin abuse. Then we have aristolochic acid consumption, and then it is also associated with non-polyposis colorectal cancer. Common symptoms is painless hematuria. Hematuria, we said, is also associated with bladder cancer, but it is very commonly associated with renal carcinoma, and it is painless. No pain is present, and there is gross hematuria. You can see the blood in the urine with the eyes. Spreads like bladder cancer, low grade, there is nephroureterectomy. So if there is spread of the cancer, we need to do nephroureterectomy, which is removal of the kidneys and the ureter. Renal cell carcinoma, 90 to 95% of the renal cell carcinomas are malignant neoplasm. So benign neoplasm of the kidneys are not common because 90 to 95% are malignant. Notable features are they are resistance to cytotoxic agent, infrequent responses to biologic response modifiers like interleukin-2, robust activity to anti-angiogenesis targeted agents, variable clinical course, anecdotal reports of spontaneous regression. So the features of the renal cell carcinoma is it is resistant to different cytotoxic agents or drug. It has infrequent response to different biological modifiers. It has robust activity to anti-angiogenesis target agent, variable clinical course. All these are the features which are associated with the renal cell carcinoma. Here you can see the kidneys with the renal cell carcinoma. Epidemiology of the renal cell carcinoma, male to female ratio is 2 to 1. So it's more common in males as compared to females. It's between the ages of 50 to 70, so it's not the cancer of the young age, it's the cancer of the middle age. Strongest association with the cigarette smoking and the syndrome known as von Hippel-Lindau syndrome, renal cell carcinoma is very, very closely associated with this syndrome. Increased risk if acquired cystic disease of the kidney is present, that is associated with the polycystic kidney disease, is common condition that is acquired inheritedly, so it is associated with that condition. Pathology and genetics of renal cell carcinoma, 5 categories of the renal cell. We have papillary tumors, which are bilateral and multifocal. Chromophobe tumors, indolent clinical course. Oncocytomas, benign neoplasm. Bellini duct carcinoma arise from collecting duct, rare but often aggressive. Clear cell tumors in more than 80% of patients who develop metastasis from epithelial cells of proximal tubules. So clear cell carcinoma of the kidneys is very common in more than 80% of the patients who develop metastasis. They have clear cell carcinoma and they develop from the proximal tubules. The other oncocytomas, they are benign neoplasm of the kidney, and we already mentioned that about 90 to 95% are malignant, so benign are very rare, like 5% or so. And then we have papillary, which are bilateral and multifocal. Classification of the renal cell carcinoma, according to the cell type present, growth pattern, cell of origin, and cytogenetics or genetics involved. Clear cell, they are the acinar or sarcomatoid type. Proximal tubule is the site of origin, and these 3P negative, 5Q plus, and 14Q are the genes involved. Papillary or sarcomatoid growth pattern, proximal tubule +7 +17 -Y. Chromophobe, they are solid tubular or sarcomatoid. They develop from distal tubule and cortical collecting duct. Whole arm loss is present in 1, 2, 6, 10, 13, 17, and 21. Oncocytic is tumor nests, cortical collecting duct, and it's the undetermined cytogenetics. Collecting duct is papillary or sarcomatoid, medullary collecting duct, and again it's undetermined. So all these are the classification depending on the cell type involved, growth pattern, and cytogenetic and site of origin of these tumors. Pathology and genetics. VHL encode tumor suppressor protein. So von Hippel-Lindau disease encodes the tumor suppressor proteins, which function in transcription of vascular endothelial growth factor, platelet-derived growth factor, hypoxia-inducible proteins. Inactivation now of von Hippel-Lindau cause overexpression of agonist of VEGF PDGF receptor. then it causes tumor angiogenesis, and then cause tumor growth. So the pathology associated with the tumor renal carcinoma, and we said that it is very commonly associated with von Hippel-Lindau disease. And then what happens in von Hippel-Lindau? It encodes tumor suppressor protein, the protein that helps in the tumor suppression. And then when that tumor suppression protein is not working, it can lead to some changes, include overexpression of vascular endothelial growth factor and platelet-derived growth factor receptors, and this can cause tumor angiogenesis and then tumor growth. Signs and symptoms are hematuria. We said marked gross hematuria. Abdominal pain, very typical classical sign is the patient usually tells you that this is the presentation on the back, that you have the flank pain or abdominal mass. Fever, weight loss, anemia, and varicocele are present. Clinical presentations, there is paraneoplastic syndromes are associated with erythrocytosis, hypercalcemia. There is increased red blood cells, increased calcium, differential diagnosis of renal mass, inflammatory lesion, and primary cancers. No metastasis, usually surgery is indicated. So if the disease is not metastasized, then the surgery can be performed to cure the disease. And differential diagnosis is different renal mass, which may be due to some other causes, maybe cyst presence, any inflammatory lesions that can lead to the features resembling the carcinoma, leading to flank pain, hematuria, and then some primary cancers. All these are some differential diagnosis. So that was all about our section 4. Thank you for watching sqadia.com.